just start all over. So let's give it another minute or two and see if everybody gets here. And then we'll start all over with call to order and roll call.
Okay, thank you. Good morning, Mr. Chair. Rob Fechner.
Good morning.
Margaret Brown.
Good morning.
Henry Jones.
Here.
David Miller.
Here.
Irene Ortega.
Here.
Ramon Rubacava.
Present. Here.
Teresa Taylor.
She's excused.
Yeah.
Shonda Wesley.
Present.
Karen Green Ross for Betty Yee. Mr. Chair, I do not show Karen Green Ross as of yet for Betty Yee.
That's fine. We will keep an eye out and see if she comes in. It might be helpful if everyone, if you're not speaking, to turn off your video. It might help with the bandwidth today. This is going to be a tough day, we can tell already. Item 2 is the approval of the November 17th timed agenda. Do we have a motion to approve?
So move approval.
Moved by Mr. Miller. Who was the second?
Mr. Jones.
Jones?
Yes.
Thank you. Any discussion on the motion? Seeing none. Ms. Hopper, please call the roll.
Margaret Brown.
Aye.
Henry Jones.
Aye.
David Miller.
Aye.
Irene Ortega.
Aye.
Ramon Rubacava.
Aye.
Shonda Wesley.
Aye.
Karen Green Ross for Betty Yee.
Aye.
And Karen, I'll go ahead and mark you in attendance as well.
Thank you.
Mr. Chair, I have David Miller making the motion, Henry Jones seconded on the approval of the timed agenda.
Thank you. Item 3 is the executive report. First, we're going to call on Mr. Sweeney.
Thank you, Mr. Chair. Good morning, members of the committee. I'm Anthony Sweeney, CalPERS team member. Grateful for the opportunity to be with you again this month. My opening comment has never been more appropriate. While 2020 has been difficult, I do have good news. There's only 6 Mondays left in this year, so have something to look forward to. And while this year's been a struggle, our teams have continued to perform exceptionally well in the remote environment. And I have a lot of news to share about activities and trends in customer service and in education since we last spoke. Our contact center team just wrapped up a very busy open enrollment season, and they've been working extremely hard to manage the increase in our call volumes. Recently, we've had some challenges with extended call wait times. Call volumes can vary for a variety of reasons, particularly during peak times like open enrollment. In addition, we've seen an overall 30% increase in call volumes over the past 2 years. And as you know, this can create customer service issues for our members and burnout or morale issues for our team. As a result, we're working diligently to mitigate both of these concerns. We are redirecting workload from our contact center to program areas, therefore freeing up more agents to take phone calls. We're also adding permanent positions from the enterprise vacancy pool to increase the number of our call agents. We're also securing additional resources to assist during peak times as needed on an ongoing basis. While it will be some time before all these new resources are fully trained, our shifting workload and utilizing resources throughout our customer services and support branch will provide immediate short-term relief. We continue to monitor workload and trends on a daily basis to identify and incorporate new strategies. In September, I updated you that overall retirements are on the decline. Over the course of the calendar year, we do continue to see an overall decrease in retirements. However, the amount of the decrease has been narrowing, as we've seen slight increases in retirements more recently. We continue to see increases in state member retirements, offsetting the decrease in schools and public agencies. We have seen the school member retirements tick up recently, and we anticipate additional increases in retirements going forward. Thankfully, as I mentioned before, online usage of our member self-service is on the rise, including nearly 70% of all retirement applications, which is nearly double the percentage from pre-COVID times. This helps mitigate the impact on our team members who process paper transactions. We continue to add member self-service functionality, and this year, for the first time, our 1099s are not only available online, but retirees also have the option of opting out of the paper mailing process. Opting out of paper helps us reduce the administrative costs of this program and helps us reduce our carbon footprint. As you know, our team continues to monitor the impacts of natural disasters in California and across the world to ensure our retirees who are still receiving paper retirement checks have access to their funds. Besides these natural disasters, the pandemic has also impacted mail delivery in some instances. I wanted to share a personal story from the team on the global front about one member in particular. We were connected with her through social media. She's based in the Philippines and is a surviving spouse of a CalPERS retiree. She could not get access to her paper warrants due to the cessation of U.S. mail delivery because of the pandemic in the Philippines. By the time we heard from her and were able to connect, she had not received several retirement checks, and she was struggling to provide for herself. Our team was able to make contact with her, provide her resources, and assist her with transitioning her payment method from paper to direct deposit, and immediately reissue the funds into her account. The member was very appreciative of the assistance provided, and I really want to thank our teams in Retirement Benefit Services and Public Affairs for their compassion, collaboration, and exceptional customer service. I'm grateful to be part of this team that provides that level of service with extraordinary care for the struggles our members face, and the level of commitment is consistently demonstrated throughout the entire organization. Lastly, we're gearing up for our next CalPERS Benefit Education Week, to be held in just two weeks from now, November 30th through December 4th. So far, we have nearly 20,000 registrants over 23 classes we'll be offering, which is just under 65% of the capacity we have for that week. For comparison purposes, the last event we held in July had about 6,000 class registrations. So we've already more than tripled that number, and we're still 2 weeks from the event. I'm also happy to share we've made many improvements based on member feedback from the first event. We've expanded the schedule of live instructor-led classes, including adding evening offerings, as well as an additional day of instructor-led classes, increasing offerings of our most highly attended classes, and in addition to classes provided by us and the Social Security Administration, we have partnered with CalHR and Nationwide to add 3 deferred compensation classes. We've improved the registration process as well, which has likely led to our increased numbers. Overall, the week will offer 23 live classes taught by our CalPERS program area experts, along with our other partners. We're looking forward to another opportunity to virtually deliver exceptional education that our members are accustomed to receiving and our team members are proud to deliver, in spite of the closure of our regional offices and many other locations where we typically deliver these in-person offerings. In conclusion, I remain extremely proud of our team for managing the current environment and delivering on our mission of serving our members and employers. I wish to thank the board for your continued support as we work through the challenges of 2020. Since I won't have the opportunity to meet with you all before the end of the year, I want to wish you all a safe and happy holiday season. This concludes my comments, and I'm happy to take any questions.
It's always great to hear when members get the satisfaction that they have come to expect. So thank you and your team for all the good work. And please pass that on for me. Let's see, anybody with any questions? I don't see any. So thank you, Mr. Sweeney. You too, you and your family have a good holiday. We're going to move on to Mr. Mold's portion. Mr. Mold, please.
Great. Good morning, Mr. Chair, members of the committee, Don Molds with the CalPERS team. We have several very substantive items on the agenda today. I have 3 short updates for the committee, and then I'd like to leave time for Julia Logan, our Chief Medical Officer, to provide you with an update on COVID-19, since there's much happening right now. First, for my update, we published our health benefits annual report for the 2019 plan year and delivered it to the legislature and the Director of Finance as required by statute. The report is item 5 on your agenda, and it's also available on the CalPERS website. It provides information about our programs, plans, and financials. You may notice that it has fewer pages as we leaned out the report to focus on the most important information and to improve our readers' experience. I'd like to thank the many CalPERS team members across the enterprise who contributed to the development and delivery of the report. We hope you find it informative and a good resource. Next, I want to let the committee know that our 2021 Health Plan Member Survey will kick off on January 11th, 2021. This is our annual survey that asks members to rate their experience with their plan and their pharmacy benefits during the 2020 plan year. We worked with an independent firm and surveyed roughly 26,000 randomly selected members across the plan. This year, we strengthened the survey and included questions on behavioral health and more complete demographic information, including race, ethnicity, sexual orientation, and gender identity. These details will help provide a fuller picture of our membership and its health status. We'll also use the survey results to measure outcomes, trends, members' care experiences, and access to care. We would ask all members who receive a survey to respond. It goes a long way in helping make the health plan better for everyone. And last but not least, I want to let you know that last week, Marcia Green was appointed to the Board of Directors of the Public Sector Healthcare Roundtable. The Healthcare Roundtable is a nonpartisan, member-directed coalition that exists to give public sector healthcare purchasers and state and local health plan administrators a voice in the design, development, and implementation of national healthcare policy. The Roundtable does this by providing in-depth policy analysis and a forum to collectively engage with key decision makers in Washington, D.C. Additionally, this month, Marcia continued to represent CalPERS members' interests in congressional office briefings, albeit virtually these days, to support a federal prohibition on surprise balance billing. Talks between congressional offices have begun anew, and there appears to be some momentum towards finding a solution to this vital consumer protection issue. She will continue her virtual Hill visits over the coming weeks. I'm going to stop there so there's time for Julia. After, if you have any questions for either of us, we'd be happy to take them.
Thank you. Morning, Ms. Logan.
Good morning. Julia Logan, CalPERS Chief Medical Officer. I will be giving you a brief update on COVID-19 treatment and vaccine updates and how our health plans are working to serve our members during this pandemic. I'm sure you are aware that nationwide, we are experiencing the dreaded fall and winter surge. The U.S. surpassed 11 million cases on Sunday, and the latest 1 million cases were added in just 7 days. The daily average of new cases is up by 80% from 2 weeks ago. For a time, it looked like California was bucking the nationwide trend, but sadly, our state is now experiencing the fastest increase in coronavirus cases since the beginning of the pandemic. Over a 7-day period beginning November 1st, the state saw a more than 50% increase in cases, and our governor announced yesterday afternoon that 94% of our state, so 41 counties, will revert back to the most restrictive purple tier effective today. The governor is also considering the possibility of instituting a statewide curfew, though his office is still reviewing the data from other states and countries that have already implemented curfews. Against this dire backdrop, there are some incredibly bright and hopeful spots around treatment and prevention that are important to highlight. Treatment of COVID has certainly improved dramatically since the early days of the pandemic. As we learn more and more about this virus, doctors and nurses just keep getting better at treating the disease. They know what works, what doesn't work. Experience has taught doctors more about whether to put people on ventilators, how much oxygen to provide, and how to prevent some of the worst effects of the disease before our immune systems have had a chance to react significantly. And most significant of all right now is the news last week from Pfizer and just yesterday from Moderna that their vaccine candidates are 90% and almost 95% effective, respectively, in preventing the disease among volunteers who had no prior infection. We have learned that these two vaccines are quite similar in efficacy because they both use the same basic vaccine design, but they do have some distinct differences. One major difference is how the vaccines need to be stored. Moderna's vaccine can be stored in a normal refrigerator for up to 30 days. By contrast, the Pfizer vaccine has to be kept at -70 degrees Celsius. This feature may make mass distribution of the Moderna vaccine much less challenging. Both these high efficacy vaccines, however, will be necessary to adequately vaccinate our population. And there are some things we still need to learn about both vaccines. We don't know how long protection will last, if they will give short-term immunity like a flu vaccine or longer protection like some of the childhood vaccines. And we don't know yet if the vaccines work in certain groups better than others. While neither trial uncovered any serious side effects, we will not know the long-term safety profile of these vaccines for some time. In terms of timeline of when these vaccines will be approved and available, we don't know exactly when, but they may be available for limited distribution to healthcare workers and those at increased risk for severe disease as early as the end of the year and widely available to the public by mid-2021. We will be following COVID vaccine distribution closely, and we continue to work with the plans on all issues related to COVID. And in fact, just completed our quarterly business reviews with each of the plans, where we discussed at length their COVID response and looking to the future regarding vaccine availability and readiness. Some of the trends we noted previously with you, such as telehealth utilization and mail order uptake of medications, continue to be high, and we anticipate that these will be long-lasting impacts of COVID-19. We continue to track grievances and appeals as they relate to COVID, and I'm pleased to say that it's been very quiet on that front. And the concerns that members had earlier in the summer around testing availability do not appear to be an issue now. And I believe that that has to do with the massive effort on the part of our health plans and the state to increase and maintain testing capacity. Testing plays a major role in fighting COVID-19, and we have been keeping close tabs on the availability for our members. Finally, as we look forward to the holidays, it's never been more important for us all to take action against the pandemic. Isolate as much as possible. Wear masks, avoid indoor groups, and all the stuff that we already know about, but that we're all understandably growing weary and fatigued. We're not going to be doing all this forever. I really think that the vaccine results may be the light at the end of the tunnel. Please hang on and stay safe. I appreciate your attention and time, and I'm happy to take questions.
Thank you, Dr. Logan. Very sobering but informing comments, so thank you very much. I do have a question for Mr. Miller.
Thank you, Dr. Logan. This question's for you or for anyone else who wants to weigh in. One of the things that I've been concerned is I've heard a number of experts express concerns about not just the logistics of deployment, but the success of deployment in terms of public acceptance and participation, you know, absent any kind of a mandate for vaccinations. And some of the polling that I saw was showing, you know, nearly half of the country saying they would not accept or would not have a vaccine imposed on them. And so I was wondering if you'd heard any more, have any more current or authoritative information on those possibilities, and what kind of plans are in place to try to counter that, and finally what we can do to urge our members to get vaccinated when it's available.
Yes, that is an excellent point and an ongoing concern. Public acceptance of the vaccine is crucial to get to where we need to go to get to herd immunity. So I know that the state and the Department of Public Health are doing all that they can to be as transparent as possible. The governor has also instituted a COVID vaccine task force to address those very issues and to vet the vaccine scientifically separate from the nationwide and the federal response. I have every confidence in the process. The process that is being undertaken right now, being led by the NIH, is rigorous and follows the process that has been followed for vaccines in the past. And so it's a rigorous process, and it goes through several independent agencies and experts. And so I feel like it's something that we as a nation need to start to trust and to understand. And I think we haven't been exposed to that sort of to this level of news about vaccines and about how vaccines are developed. So I think it's new to people, and so getting to understand how it really works is very important. But yes, I appreciate your concern, because I share it as well.
Thank you.
Thank you. I see no other request to speak, so thank you, Dr. Logan. Anything else, Mr. Molds?
Nope. Yeah.
All right. That moves us to agenda item 4, the action consent items, the approval of the September 15th Pension and Health Committee meeting minutes. What's the pleasure of the committee?
So moved.
I will second.
Moved by Mr. Miller.
Ramon Rubalcaba seconds, Mr. Fechner.
Thank you. Seconded by Mr. Rubalcaba. Any discussion on the motion? Seeing none. Ms. Hopper, please.
Margaret Brown,
Aye.
Henry Jones, Henry Jones,
Aye.
David Miller,
Aye.
Elena Ortega,
Aye.
Ramon Cava,
Aye.
Teresa Taylor,
Used.
Shonda Wesley,
Aye.
Karen Green Rochford, Betty Yee.
Aye.
Mr. Chair, I have David Miller making the motion, Ramon Rubalcaba seconding it. For agenda item, the approval of the Pension and Health Benefits Committee meeting minutes.
Thank you. Moves us to agenda item 5, the information consent items. I do have a request to take item 5C separately. So we have, again, no other requests. So let's move to item 5C. I have Ms. Green Ross that had a question.
Thank you, Mr. Fechner. My question is about the employee survey. In August of last year, in September, we had hearings on mental health access and parity, and we were going to include that in the survey. And when I look at the page 15, which sort of briefly summarizes the survey results of our beneficiaries, I just wanted to know if that was incorporated or that's being done separately.
Yeah, I appreciate your question, Ms. Greenross. So we made a call about 3 weeks ago as we were looking at the cumulative amount of material for this board meeting and the need to really dive in on the behavioral health issue. We've heard that it's a critical issue for you as a board, and rightly so for us as well. So what we decided to do was to move that entire agenda item to the January offsite and give it more time than we would have been able to give it today. So we have a full presentation that will be and discussion that will be led by Dr. Logan that's queued up for the January offsite.
And did we survey employees, or we're still working on how to incorporate a survey of that? The beneficiaries.
Dr. Logan can speak to the specifics of the survey.
Yes, so this is Julia Logan. We have a health plan member survey where we did add specific behavioral health questions around access and a member experience. So we can talk more about that at the January offsite.
Right, I just was trying to understand in the context of this report that we sent to the legislature. There was no mention of that.
That was the 2019 report, so that dates back a full year.
Ah, okay. Appreciate that then. Thank you very much. I'll look forward to the January offsite where we can discuss it more. Thank you.
Yep.
Thank you. Seeing no other requests, we move to item 6, the action agenda item. 6A is the approval of new health plans, benefit designs, and service area changes. Mr. Moulds?
I'm going to turn it over to Marcia Green.
Very good. Good morning, Ms. Green.
Good morning, Mr. Chair and members of the Pension and Health Benefits Committee. Marta Green, CalPERS team member. This is agenda item 6A, approval of new approval of new health plans, benefit designs, and service area changes. This is an action item. For the agenda, next slide, please. For the agenda, we'll go through the timeline, plan proposals for 2022 by carrier, and then discuss next steps. Next slide, please. So here's our timeline. In August, CalPERS asked the HMO health plans to submit proposals for any changes to their existing plan products or to add plan products for CalPERS consideration. In September, Anthem Blue Cross, Blue Shield of California, United Healthcare, and Western Health Advantage submitted proposals for consideration. The submissions included applicable pricing, provider network and coverage area, benefit design information. The CalPERS team conducted an extensive analysis to determine any added value these proposals will bring to the CalPERS health benefits program. The analysis consisted of the network coverage areas, numbers of providers, coverage overlaps, projected administrative services fees, and medical costs. I'm going to walk through each plan proposal separately and provide the team's recommendation based on our analysis. Any approved plan proposals will be incorporated into the 2022 rate development process beginning early next year. Next slide, please. Anthem Blue Cross Medicare Advantage plan is currently offered in 37 counties in California. This proposal would expand their Medicare Advantage plan into 21 additional counties, converting it into a statewide option. This service area expansion provides members, particularly in rural counties, with more choices. The projected increase for the expansion of premium is $4.73, or a little over 1% increase. The proposed benefit design aligns with CalPERS standard Medicare Advantage benefit design, and the team does recommend approval of this proposal. Next slide, please. In addition, Anthem is offering 2 new benefits for the Medicare Advantage plan: Healthy Pantry and non-emergency transportation. Healthy Pantry offers 12 telephonic nutritional counseling sessions, plus a monthly shipment of non-perishable items. Non-emergency transportation offers 12 one-way trips up to 60 miles to approved locations. The addition of these two new benefits will add $2.86 or a 0.75% increase in the premium. These proposed benefits are consistent with the additional supplemental benefits in the Chronic Care Act and meet our stakeholder expectations by adding Medicare Advantage benefits where appropriate and cost-effective to help keep our members healthy and provide additional access to care options. As a reminder, Kaiser and United Healthcare offered similar benefit changes approved for the 2021 plan year. The team recommends approval of this proposal. Next slide, please. Blue Shield of California is proposing to re-enter Access Plus into 8 of the 9 Bay Area counties it exited in 2019, all of the counties it exited except for Napa. This proposal is contingent upon board approval of the risk mitigation strategy for 2022. As background, the elimination of risk adjustment for the 2019 plan year would have resulted in a significant increase to the Access Plus premium. To partially mitigate, Blue Shield exited out of 9 higher cost Bay Area counties. Blue Shield projects a 1.6% increase to the current Access Plus pricing, and there are no benefit changes associated with this proposal. This is the first of a few proposals that we are going to recommend approval contingent on the results of our basic plan competition study. As we've discussed with you previously, we've engaged a team of economists to study the right mix and concentration of plans in each of our distinct geographies to inform the footprints of the plans in our portfolio. The results of this study are expected in January. So for a few of these proposals, we are recommending that the board approve the continued development of the proposal and rates pending the outcome of the competition study. We plan to bring you the results of that study in March, which will include the counties appropriate for expansion. So the CalPERS team recommends approval with the understanding that the proposal is contingent on board approval of the risk mitigation strategy and the results of the competition study. Next slide, please. Blue Shield is also proposing to expand its Access Plus EPO product into 2 rural counties, Lassen and Shasta, contingent upon DMHC regulatory approval and board approval of the risk mitigation strategy for 2022. The Access Plus EPO plan is currently offered in Colusa, Mendocino, and Sierra counties. By adding Lassen and Shasta, rural county members will have more choice as they are often limited to only the PERS PPO plans. Blue Shield projects a small financial impact of 0.15% increase to the current Access Plus pricing, and there are no benefit design changes associated with this proposal. The CalPERS team recommends approval with the acknowledgement that this proposal is contingent upon DMHC regulatory approval and CalPERS board approval of the risk mitigation strategy. Next slide, please. Blue Shield is also proposing to expand its TRIO plan into 4 counties: Monterey, Santa Cruz, Orange, and Stanislaus. Of those counties proposed, Monterey is the only county that does not currently have a low-cost HMO option, as 3 other counties have varying levels of plan concentration. Monterey County is contingent upon successful provider negotiation and DMHC regulatory approval. Blue Shield anticipates no financial impact for expanding TRIO service area, and there are no benefit design changes associated with this proposal. The CalPERS team recommends approval of the expansion into Monterey with acknowledgement that it is contingent upon successful provider negotiation and DMHC approval. Additionally, the team recommends approval of the remaining 3 counties, Santa Cruz, Stanislaus, and Orange, if the competition study indicates these counties are appropriate for additional plan offerings. The team will provide an update at the March PHBC meeting, including whether these counties should be included in the expansion. Next slide, please. Blue Shield is proposing 2 options, a 58 county and a 41 county, for a new Medicare Advantage plan that would include prescription drug coverage. The 41 county proposal matches Blue Shield's proposed Access Plus and TRIO service areas for 2022, and the 58 county is a statewide option. This proposal would allow members to remain with the same carrier as they age into Medicare. The proposed benefit design aligns with CalPERS standard Medicare Advantage benefit design, but includes some other benefits as well. A $80 quarterly over-the-counter drug benefit, personal emergency response system, post-discharge meals, and 24 non-emergency one-way trips for transportation. It also includes an option for dental and vision benefits for contracting public agency members. Next slide, please. The projected single party premium for the 58 county option is $346.87. The 41 county option is slightly lower at $346.83. There is no significant single party premium difference between the two options, and the 58 county option provides statewide service area coverage for Blue Shield's Medicare Advantage members. The CalPERS team recommends approval of the 58 county option. Next slide, please. United Healthcare is proposing a nationwide Medicare Advantage plan in which prescription drug coverage would be carved out and provided by Optum Rx under our direct contract. This plan is being offered in addition to United Healthcare's current Medicare Advantage product that has an integrated pharmacy benefit. The proposed benefit design reduces member cost sharing to zero for most services, similar to CalPERS self-funded Medicare supplement PPO plans. Due to the reduction in cost sharing, United Healthcare projects a higher medical cost compared to the current United Medicare Advantage product. The overall projected 2022 premium is in between the current Anthem and Kaiser Medicare Advantage plan premiums. The CalPERS team recommends approval of this proposal. If approved, CalPERS will allow other carriers offering Medicare Advantage plans to propose to reduce member cost sharing as part of the 2022 rate development process. Next slide, please. United Healthcare is also proposing its signature value Harmony Basic HMO narrow network plan in 5 Southern California counties: Los Angeles, Orange, Riverside, San Bernardino, and San Diego. The number of HMO offerings in these service areas ranges from 7 to 8 plans. This new plan is projected to be either the second or third lowest HMO premium in the 5 counties. The proposed benefit design aligns with CalPERS standard basic plan benefit design with a focus on physician-patient relationships. The CalPERS team recommends approval of this new plan if the competition study indicates that these counties are appropriate for additional plan offerings. The team will provide an update at the March PHBC meeting to confirm whether this new plan should be included and in which counties. Next slide, please. United Healthcare is also proposing to introduce its self-funded doctors EPO plan into 9 Bay Area counties. And this is in partnership with Canopy Health. This is a self-funded plan proposal, and United Healthcare would act as a third-party administrator. The CalPERS team recommends not accepting this proposal until such time that the self-funded PPO procurement is conducted, and the current self-funded PPO contract expires in 2024. Next slide, please. Western Health Advantage is proposing a new MyCare Medicare Advantage plan in which prescription drug coverage would be provided by Optum Rx. The 2022 premium projected is $359.62. The proposed benefit design aligns with CalPERS standard Medicare Advantage benefit design. This plan would allow members enrolled in Western Health Advantage basic plan to remain with the same carrier as they age into Medicare. The CalPERS team recommends approval of this proposal. Before I move on to the summary for today's proposals, I'd like to share another exciting potential development for Western Health Advantage. They recently filed for regulatory approval of an expansion into Humboldt County and hope to offer this product to CalPERS for the 2022 plan year. This county currently does not have a low-cost HMO option and has a concentration of public employees as there is a large state prison in the county. Western Health Advantage intends to submit this expansion for consideration, and we plan to bring the recommendation to the PHBC in March. Next slide, please. So this table summarizes the plan proposals. You'll see we have the various proposals that we would recommend approval, those that we would recommend approval pending the outcome of the competition study, and the one that we recommend disapproval. Now we'll talk about next steps. Any approved plan proposals will be incorporated in the 2022 rate development process. The CalPERS team will continue to work with each carrier on their approved proposals. Once the results of the competition study are received, we will confirm which counties for each plan are appropriate for expansion at the March PHBC meeting. The team will present preliminary and final rates in summer of 2021 for the 2022 plan year. That concludes my presentation, and I'm happy to take any questions.
Thank you, Ms. Green, for a very succinct report. I do have a couple of questions pending. Mr. Jones.
Yeah, thank you, Mr. Chair, and thank you, Ms. Green, for, again, an excellent presentation as usual. A couple of questions. One is that I noticed that there are 3 items that are pending, approval pending based on additional study research. So why are we asking to approve those now when we'll have to revisit them when you complete your work or study?
That's a great question. Thank you, Mr. Jones. So really what we want to know is if any of these should be disapproved by the board, we will stop development of those before we move into the next cycle. But if the board is comfortable with these moving forward pending the outcome of the competition study, we would come back in March for final approval of those. So this is an early indication of whether or not the board is interested in some or all of these. Those that the board may not be interested in, we would not move forward with continued development. Those the board is interested in, we would continue to develop and confirm specifically which counties in March.
Okay, thank you. And my next question is, I think it's on the iPad, page 74. I think that's the page. Let me see if I could go back to it. Uh, 74. Yeah, 74. And Anthem Blue Cross, the non-emergency medical transportation now is a projected premium impact of $2.86, and it includes silver sneakers. Now, I thought that was a complimentary benefit in the past. So why now are they including it as a charge?
Thanks, great question. So Silver Sneakers itself is complimentary. It's the transportation to and from a Silver Sneakers location that is incorporated in the non-emergency transportation.
Okay, okay. Thank you very much.
You're welcome.
Thank you. Ms. Brown.
Thank you, Mr. Chair. Marta, that's a very fast and detailed presentation. Thank you. I was very happy to hear about Western Health Advantage coming up with the plans as people age into Medicare. That's exciting. And also, more importantly, the potential HMO for Humboldt County. That is so exciting. You know, it's interesting as the state plans prisons in these rural counties, they actually don't plan for services for all the state employees. And so this is very exciting that Western Health is going to do this. So what's the likelihood that they'll get approval to do that? I mean, is it more likely or less likely?
They're feeling very confident about the expansion, and it has already been filed for regulatory approval. And so that happens pretty late in the development. There's never a 100% guarantee, but I'm feeling pretty confident.
Well, I'm so excited for our state employees or retirees out in Humboldt County. This could be a real money saver for them. Thank you.
Great.
Thank you, Mr. Rubalcaba.
Thank you, Mr. Fechner, Chair. Thank you, Martha, for excellent presentation, and congratulations on being appointed to the Public Sector Roundtable.
Thank you.
So, and it's good to hear that our insurance carriers are proposing new plans and expansion of service area. My question is more, I understand that we have to wait for, some of them are contingent, the risk mitigation adjustment, and others are based on the competition study, because we want to make sure that we have the right mix of plans in any one area, especially Southern California and areas where there's a lot of competition already. So my question is, through the rate development proposal, even though we're trying to do these new studies, through these new approaches, the risk mitigation and the competition, trying to make sure that the people are competing based on quality of care and their primary care physician networks and stuff, and not necessarily trying to get out the risk pool. So all this, the carriers will have to weigh in, whether, say, Southern California, whether there's, you know, a new neural network or quality network, what have you, or new expansion everywhere. So does the time frame allow for them to get a sense of who's their competition, so to speak, before they submit rates, or will they have to submit rates and then there's an opportunity for them to adjust based on who's in the pool with them? So I'm trying to understand how the timeline works.
That's a great question. Thank you for that question. So part of the reason we're bringing this to you now with the way we've constructed our approval is so that all of the carriers see what all of the carriers have proposed. Now, they will have to develop rates and submit rates before we confirm the final county lineup, and we will make any adjustments based on the final county lineup that we bring to the board at the March PHBC. However, they are at least aware of what's proposed and what's possible. In the previous years, if you recall, or at least in recent years, those proposals have been part of the confidential rates process, and so plans didn't know what the other carriers were doing until we got to preliminary rates in May. And that's what caused a lot of the lack of transparency and misunderstanding of what the market was doing. But by doing it this way, we have transparency. All of the carriers know what is being further developed. They can take that into consideration when developing rates, and depending on the final lineup of both plans and service areas, they can adjust their proposed rates accordingly.
Thank you for explaining that, and I really appreciate the report. Thank you very much.
And this is Don. I'll just add in that that this two-step process that Marta described, where we come back to you with the final results of the competition study, that's this year only. Going forward, we'll have that fully in place. It will be something known to us, to the carriers, to you, and so we'll be able to do this in November with full information.
Great, thank you, and thank you both. Thank you for the explanation, Ms. Green. It would be nice to not have to play the I gotcha, what if game every year, so it's just good to put it out in front. All right, Mr. Miller with a comment.
Yeah, two kind of comments on, well, actually three. First is thanks for the really nice, concise, illuminating presentation. I really appreciated it. It was really on target, so I have no real questions about it. I do really look forward to December, and particularly the information on the those that are kind of pending further information. And before I've mentioned that I still have concerns and really want to hear in December about, for example, TRIO, this move toward these lower cost, higher deductible, the kind of potential adverse selection, competitive issues with that certainly concern me and a lot of our members and stakeholders. And the second thing is I'll be curious to see if we're probably just starting to give some thought to this, but it kind of relates to Director Brown's comment about how nice it is to see, HMO in Humboldt, because I think not just Humboldt, but a lot of our rural locales are going to see, at least from state employees, a lot more people residing there a lot more of the time. We've learned with the distance and teleworking that we don't really need to have the concentrations of employees physically in, a 25-story building in Sacramento, for example, that people can do a lot of their work. And I think the new normal after we get to it is see a lot more people be able to enjoy rural living if they so choose, which may impact the pattern of kind of the needs assessment of our membership out there. So I'll be interested to see as we go along how that dynamic develops.
Thank you, Mr. Miller. Thank you. And I agree. Expanding rural access is a top priority for both Mr. Moltz and me. One thing I want to clarify about TRIO is it actually doesn't have any higher cost sharing than our other HMOs. All of our HMOs have exactly the same benefit design, no higher deductibles. The difference is it's a narrower network. So Blue Shield Access Plus, in contrast, is considered a broad network HMO, and the TRIO is a tailored network, but the cost sharing, the out-of-pocket cost, the out-of-pocket exposure is identical.
Yeah, thanks for that clarification.
You're welcome.
Very good, thank you. Mr. Rubalcaba.
Thank you again, both Don and Martha, for a great presentation. And given their presentation, I think it's appropriate to have a motion to approve the staff recommendations and so of approval contingent on the competition study results. And I will so move.
Second.
I'll second that. This is David Miller.
Mr. Miller seconding. Any discussion on the motion? Seeing none, before we vote, we do have a couple of members from the audience that would like to make comments. Mr. Fox, I believe we have Mr. Behrens and Mr. Jelensik on the line. Can you please invite Mr. Behrens to make his comments?
Yes, Mr. Chair, we have 3 callers in total on 6A. First, we'll have Mr. Tim Barron.
Thank you, Kelly. Chairman Fox, there are members of the committee, members of the board. CSR is speaking in complete support of the staff recommendations. I want to thank Marta and Don and your health team for a great presentation. I really like that our members are going to have more choices, that there's been more additional rural areas added at a minimal cost and increase in cost, and they will continue to provide quality medical services. So we speak in support of the recommended action. Thank you much. Have a good day.
Thank you very much. Mr. Fox.
Yes, Mr. Chair. Next up, Mr. J.J. Jelensik.
Hi, J.J. Jelensik, beneficiary. I'm not going to advocate a position. I do want to make an observation and point out something the board needs to consider. The agenda item proposes new benefits and expansion into new geographic areas. All things being equal, more is better. However, the agenda points to one of the most consistent things about insurance. The greater the benefits, the greater the premium. As trustees, the board gets to exercise its expert, prudent opinion as to whether the increased benefits are worth the increased costs. On the question of expansion into new geographic areas by several plans, several have indicated an increased cost related to the expansion. Most are dependent on CalPERS agreeing to subsidize the expansion into areas where they cannot compete on their own. Again, as trustees and expert prudent persons, the board gets to exercise its judgment. Thank you for your consideration.
Thank you. Mr. Fox.
Yes, Mr. Chair. The last speaker on item 6A is Mr. Larry Woodson from CSR.
Good morning. Can you hear me okay?
Hear you just fine, sir.
Okay. Larry Woodson, CSR. Thank you, Mr. Fechner, Chairman Fechner, and committee members for the opportunity to comment. First of all, I'd like to also add congratulations to Marta Green for her appointment to the California Healthcare Roundtable. This really just marks a continuance of CalPERS involvement in that forum, and I've been to several of the meetings over the years, and it's a really good opportunity.
Hello.
Can you hear me?
First of all, I'd like to also add congratulations to Marta Green for her
feedback.
To the California.
Hello? Okay.
Hello.
Okay, I'll continue. Anyway, congratulations to Marta. We've, as Tim said, we've reviewed the proposal, the changes, the additions, consider them all very positive for our members. They'll increase choice, expand geographic access. I also like the addition of supplemental benefits. That's been incremental. We've been urging that over a couple of years now. It's also especially good to see Blue Shield Access Plus proposing to return to the Bay Area, which they exited and caused a lot of disruption to our members. 2 years ago when CalPERS left or abandoned the risk adjustment policy, the old one. So, I don't think the increases in prices that Mr. Jelensik cited are a major concern. At least what was cited by Marta seemed to be very minimal. I commend staff on their good work on this and in releasing it early rather than dumping it all on members at the same time of the rate development. So appreciate their work, and we urge board approval of all the proposals. Thank you.
Thank you. Anybody else? Mr. Fox.
Mr. Fechner, can I speak to the cost issue for 1 second?
As soon as we find out if there's any other callers. Mr. Fox?
Yeah, no more callers, Mr. Chairman, on item 6A.
Great, thank you. Mr. Moles, please.
Thanks. So I certainly appreciate Mr. Jelensik's concern about keeping premiums as low as possible and the relation between increased benefits and increased premiums. In this particular instance, the Chronic Act that was passed federally was passed on a bipartisan basis with the theory borne out by experience that investments in these kinds of non-medical health options can actually, over the long term, significantly reduce costs. So a lot of them are directed at the goal, the overarching goal of keeping people out of hospitals, which is where the costs really lie. So we will see in our own experience over years as we adopt some of these in our plan, but in other places, you see these being cost effective for that reason in particular.
Very good, thank you. I have Mr. Jones with a comment before we vote.
Yeah, thank you, Mr. Chair. Yeah, just a technical, I heard Mr. Miller indicate that we will be reviewing these in December, and I just wanted for our viewing public to note that our revised schedule shows that this is coming back in November. That's all. Thank you.
Very good, thank you. Seeing no other requests to speak, a motion being before you, Ms. Hopper, please call the roll.
Margaret Brown. Aye. Henry Jones.
Aye.
David Miller.
Aye.
Irena Ortega.
Aye.
Ramon Rubalcaba.
Aye.
Teresa Taylor.
Excused.
Shonda Wesley.
Aye.
Karen Greenroch for Betty Yee.
Aye.
Mr. Chair, I have all ayes, and I believe I have Ramon Rubalcaba making the motion and David Miller seconding.
You are correct. Thank you very much. Thank you, Ms. Green. And again, I also, on behalf of myself and the committee, want to congratulate you on your new appointment. Obviously, they recognize talent, so thank you for representing us there. Brings us to item 6B, risk mitigation strategies. Mr. Moulds?
Thank you, Mr. Chair. I'll be turning it over to Ms. Green one more time. Actually, 2 more times.
Thank you, Mr. Moulds and Mr. Chair. Again, Marta Green, CalPERS team member. I'm here with my second agenda item, 6B, HMO and PPO risk mitigation strategies. This is an action item. This is a culmination of multiple conversations we've had regarding how risk fragmentation is creating adverse selection and instability in the CalPERS portfolio. Over the past several months, we focused on refining the risk mitigation approach and engaged in multiple stakeholder discussions. Today, I'm excited to share our final modeling results and provide our recommendations for a comprehensive approach to risk mitigation and the CalPERS basic portfolio. Next slide, please. I'll start with a refresher on the challenges our portfolio faces related to risk concentration, as well as a brief history of CalPERS risk mitigation strategies. I'll discuss our analysis for portfolio rating and the final methodology. Then we will dive into our updated modeling results for the proposed methodology for the HMO and PPO basic portfolio, including replacing our current 3 basic PPO plans with the proposed PERS Platinum and PERS Gold plans. Finally, we'll provide the team's recommendation for your approval. Next slide, please. I'll start with a review of the challenges we face in the basic portfolio. Since the removal of risk adjustment just 2 years ago, a significant disparity in the premiums for our basic health plans has arisen. This is because premiums are no longer priced based on their value, but rather on the concentration of healthy or unhealthy lives in each plan. Without mitigating the impact of risk concentration, health plans are forced to reduce their healthcare costs to remain competitive by introducing network alternatives that only attract healthy risk, exiting high-cost areas, and or removing providers that do an exceptional job of treating high-cost conditions. In short, plans are not competing on cost and quality, but instead on how they can attract members that use little or no healthcare. We've spoken at length about the instability that this causes in the portfolio. If we don't mitigate the risk concentration in our basic portfolio, two things will happen. The first is that we will continue to experience large member migration patterns and various plan offerings will be unsustainable. We are now only 2 years out after removing risk adjustment. We already have 2 HMOs and 1 PPO plan and a death spiral. This volatility is not only hard on our members, but it puts sustainability of our program at risk. The second thing that will continue to happen without risk mitigation is that plans will continue to compete on attracting healthy lives as opposed to competing on cost and quality of care. This is in stark contrast to our goals of having health plans do a better job negotiating with providers to bring costs down and to improve the quality of care provided to our members regardless of their health conditions. We will not be able to achieve these goals without a comprehensive risk mitigation strategy. With a comprehensive risk mitigation strategy, instead of focusing on mitigating adverse selection, we can appropriately focus our time and energy on innovative cost-saving and quality improvement programs, bringing the right kind of plan competition into each geography of our state and encouraging the right provider partnerships to deliver care in a low-cost, high-quality setting. Next slide, please. Let me give you a quick recap of what led to this conversation today. The previous risk adjustment program started in 2014 and lasted until 2018. It was terminated beginning in the 2019 plan year due to the complexity and lack of transparency with the prior risk adjustment model. Since then, premium changes have triggered large member migration patterns between the plans and unhealthy concentration of risk in certain products. The committee and stakeholders shared concerns regarding the premium volatility and stability in the basic portfolio. Following the focusing first on the PPO portfolio, the CalPERS team launched the PPO assessment in October of 2019 to understand the cause of the premium disparities between the PPO basic plans and to help inform proposed changes to the program. In January, stakeholder and member input was collected through the stakeholder forum discussion on risk concentration and through surveys that went out to PPO basic members. Through the PPO assessment, we identified that risk concentration and adverse selection are the key issues facing the PPO program. At the July offsite, we expanded the PPO assessment to look at instability and adverse selection in the entire basic portfolio. We investigated a list of potential solutions and modeled premium impacts for the next several years under each scenario. The preliminary results from the modeling of risk mitigation for the HMO and PPO basic plans were shared at the September PHBC meeting, and we are here today with refined results and to provide our final recommendations for CalPERS risk mitigation strategies and ask the committee for approval. Next slide, please. So in September, we discussed several potential risk mitigation approaches. We discussed and modeled a reinsurance approach. The challenge of this methodology is it still incentivizes health plans to chase healthy risk, and the modeling shows this approach would only partially mitigate the risk, and the resulting premiums would not reflect the plan's value. We also discussed the approach of merging plans or simply removing plans that are currently unsustainable. Unfortunately, this approach would also not move the remaining plans' premiums closer to their value. Finally, we introduced the approach of portfolio rating. It is a risk mitigation methodology designed to address the fundamental cause of our portfolio instability by ensuring our plans are priced based on their value and incentivizing our carriers to manage the health of our members. Portfolio rating is a front-end pricing model where we would continue to aggressively negotiate rates with our carriers as we always have. What's different is when the premiums are published for our members, the risk component would be removed from the rate. All products would be priced risk neutrally. I would like to emphasize how transparent this approach would be. CalPERS would routinely publish each plan's risk score before, during, and after rate negotiations. That information would be available to the public on our website so anyone could review it. Portfolio rating is an approach similar to the one used in most of the large group commercial market and by some states. Next slide, please. So what's the difference between the old risk adjustment methodology implemented in 2014 and this proposed portfolio rating approach? First, the previous risk adjustment method involved a lengthy four-stage process, including complex back-end fund transfers between health plan subaccounts in our healthcare fund. One risk adjustment cycle from phase 1 premium setting to phase 4 final reconciliation would take an entire 2-year period to complete. Secondly, the previous risk adjustment process lacked transparency, which caused challenges in projecting healthcare costs for premium setting. The overly complex process, combined with the lack of transparency, caused significant administrative burden and premium volatility. Based on the lessons we learned from the previous risk adjustment program, we are now proposing a simplified approach, which would have only a single step to set premiums at the front end. We will use a broadly accepted risk scoring model and be transparent with our process. Finally, premiums will be set in a revenue neutral manner for the entire basic portfolio to ensure total premium collected will be sufficient to pay for the members' healthcare costs and administrative fees. Therefore, no back-end money transfers and reconciliations are needed under this approach. Next slide, please. So let's discuss the details of the portfolio rating methodology. First, we are using the Milliman Advanced Risk Adjusters, or MARA, perspective as the risk scoring tool. In the past couple of months, the team analyzed 3 risk score models: MARA Concurrent, MARA Prospective, and the Department of Health and Human Services Hierarchical Condition Category, also known as the HHS-HCC. We compared each plan's risk score with claims, premiums, and pharmacy costs. We surveyed the market to learn which risk scoring tools are used by other organizations and consulted with actuaries that support other states and large group purchasers. We also discussed the various risk scoring tools with the health plans. Based on our analysis and the feedback we received, we learned that the MARA perspective would be the best fit for the CalPERS population and the portfolio rating approach. It is specifically designed to predict healthcare costs in the upcoming year, as opposed to MARA Concurrent or the HHS-HCC model, which are designed to predict costs in the current year. The MARA perspective is the risk scoring tool used by the state of Washington in their current risk adjustment process for the portfolio of products they offer to their public employees. Secondly, we address the issue of volatility in risk scores for plans with relatively small population. The risk score for each individual health plan will be credibility adjusted based on the plan size, and I'll talk a little bit more about credibility adjustment on the next slide. We are also recommending a 2-year phase-in approach. Upon implementation of portfolio rating, there could be some changes in the first-year premiums for some plans. In order to reduce volatility and smooth premiums, a 2-year phase-in is recommended to split the portfolio rating impacts between year 1 and year 2, meaning that part of the change would occur in 2022 and full implementation would take place in 2023. The phase-in approach also includes having HMO and PPO rating as 2 separate risk pools, and ultimately moving the entire basic program toward a single risk pool in the future. Next slide, please. As I mentioned, the risk score for individual health plans will be credibility adjusted based on the plan size. Credibility adjustment is a standardized actuarial approach when calculating risk scores, medical loss ratio, and other financial measures in small plan sizes. It is used in both Medicare and Medicaid programs, as well as by state insurance regulators. Generally speaking, risk score is a measure of how costly an individuals are based on their medical needs compared to the average. A CalPERS member with a risk score of 1.00 means that that person's medical costs are the average of the CalPERS basic program. Similarly, a risk score lower or higher than 1.00 means the person's medical costs are lower or higher than average. At a high level, the risk neutral premiums for each health plan is set by removing the average risk score from the medical and pharmacy costs for members who are enrolled in the plan. This means that the accuracy of the risk score is very important. Based on a 2012 Society of Actuaries study, after a plan gets to 25,000 members, the accuracy of the risk score is not increased significantly when adding additional members. Therefore, in our analysis, we assume the plan-specific risk score is considered 100% credible or accurate when enrollment size is of 25,000 or larger. Credibility adjustment is applied to risk scores with plans of enrollments of sizes of less than 25,000 based on that standard actuarial credibility calculation. Next slide, please. Next, let's look at the updated modeling results for the HMO based on the final proposed portfolio rating approach. The modeling results include 5-year premium projections using the MARA prospective risk scoring tool in a 2-year phase-in. Again, a credibility adjustment is applied to health plans with health plan risk scores for health plans with enrollment less than 25,000. HMO plans subject to this adjustment are Anthem Traditional, Blue Shield Trio, HealthNet Smart Care, Sharp, and Western Health Advantage. One exception is HealthNet Saluti Moss. It is a cross-border health plan with very unique demographics. Currently, there are also reporting issues related to the healthcare claims incurred in Mexico. The team is investigating the potential treatment for saludimas and will report back to the committee with our final recommendation in March. It may be appropriate to exclude this plan from portfolio rating for the first year while we refine the most appropriate approach for this very unique offering. Please note that these are just projected premiums that we are sharing today and solely for the purposes of the risk mitigation discussion, and they are not representative of final premiums, which will be aggressively negotiated by the CalPERS team and approved by the PHBC each summer. The modeling considers average annual healthcare unit cost increases in making its projections. Next slide, please. Before going into the modeling for individual HMO basic plans, I want to give you a global look of what's happening now in the HMO portfolio and how it would look in a portfolio rating environment. If we don't manage the risk within our portfolio, the basic plan premiums will continue to be impacted by adverse selection. As the healthier members migrate to lower cost options, the broad network plans retain a greater proportion of high cost members with more healthcare needs relative to other plans. While the differences in the concentration of high and low health risk among the plans keeps increasing, the model shows an increasing disparity between premiums and product values. This is an updated slide compared to the one we showed you in September. We now included all basic HMO plans except for HealthNet Saludimas. On the left here, you will see the projection for single party premiums for the next 5 years if we do nothing to mitigate risk. As you can see, we have different products on very different trajectories due to risk concentration. A steeper line means they're getting more unhealthy lives, or healthy lives keep moving out of the plan over time. Anthem Traditional is the most significant, as this product is currently being heavily selected against, and Blue Shield Access Plus and HealthNet Smart Care are close behind. On the right is the 5-year single party premium projection if portfolio rating is implemented in 2022. This is without a 2-year phase-in. As you can see, this is a much more stable environment with much more regular and anticipated premium changes year over year. The differences between the lines reflect the value of the product regardless of the risk concentration in each plan. Next slide, please. This slide is similar to the last one with the status quo on the left, but on the right is the 5-year single party premium projection for risk mitigation with a 2-year phase-in. In this scenario, we split portfolio rating impacts between year 1 and year 2, meaning that part of the change would occur in 2022 and full implementation would take place in 2023, which allows members to adjust to the changes with a portfolio rating. Next slide, please. Let's look more specifically at each health plan and compare the premium projections under current pricing versus the premium projections under portfolio rating with a 2-year phase-in. On the left is Anthem Select. The pink bars represent the projected premiums for 2022 to 2026, which is pricing based on risk. The green bars represent the premiums for the plans priced risk neutrally with a 2-year phase-in. As a reminder, Anthem Select is currently underpriced due to the concentration of healthy risk. As you can see, the portfolio rated premium for 2022 is similar to the current pricing due to the phase-in, and then premiums are fully reflecting plan values starting in 2023 and beyond. On the right is Anthem Traditional. It is offered in many higher cost, lower competition areas of our state. Unlike Anthem Select, Anthem Traditional has a concentration of unhealthy risk. The projected premiums under portfolio rating are priced based on the plan's value and are much more stable year over year. Next slide, please. On this slide to the left is Blue Shield Access Plus, which displays a similar pattern as I just described for Anthem Traditional, with more stable premium increases under portfolio rating than under the current pricing. On the right is Blue Shield Trio. It's the new ACO HMO plan available in 6 counties, started in the 2020 plan year and expanded to 9 in 2021. The premiums under portfolio rating are credibility adjusted. As you can see, after portfolio rating, the rates are slightly above the current pricing. Next, we have HealthNet Smart. Next slide, please. Next, we have HealthNet Smart Care and Kaiser. HealthNet Smart Care on the left sees a similar pattern to Anthem Traditional and Blue Shield Access Plus, with more stable year-over-year premium increases and lower overall projected premiums under the portfolio rating environment. Kaiser has similar results under both scenarios. This is because Kaiser has the largest population of the entire HMO basic portfolio, nearly half of all of its members, and as a result, Kaiser's risk score is very close to 1. It's just slightly below. Next slide, please. Here we have Sharp and United Healthcare. Similar to Anthem Select, both Sharp and United Healthcare are currently underpriced due to the concentration of healthy risk. The projected premiums under portfolio rating are higher compared to the current pricing, which better reflect the value of the product. Sharp's premiums are credibility adjusted due to the low plan size. Next slide, please. Lastly, we have Western Health Advantage. It has similar premium projections for both scenarios. This is because the average risk score for Western Health Advantage's population is similar to that of the overall HMO basic program. Its risk score is also credibility adjusted due to low enrollment. Next slide, please. Next, we will discuss the updated results from the modeling of portfolio rating for the PPO basic health plans based on the final proposed methodology, including replacing current PERS basic PPO plans with the proposed PERS Platinum and PERS Gold. Similar to the HMO plans, we will show you the projected premiums under the current pricing if we don't mitigate risk and what it would do under the portfolio rating environment. Next slide, please. Before I dive into modeling results, I want to emphasize the different portfolio rating approach for PPO compared to HMO. As we discussed in September, our PPO plans are administered by a single third-party administrator, currently Anthem Blue Cross, with the same business model, same care management tools and approaches, same underlying provider contracting, same leverage in provider negotiations, and the same geographic footprint, which is the whole state. We are able to price each PPO plan based on the network and benefit differentials, while for the HMO, we have to utilize a risk scoring tool to remove the underlying health risk from pricing. Next slide, please. First, we will show you what will happen if we don't manage risk within our PPO portfolio. On the graph, the orange bars represent the 5-year premium projections for PERS Care. The green bars in the middle are the premium projections for PERS Choice, and the blue bars are PERS Select. Just as a reminder, PERS Care is a broad provider network PPO plan with a richer benefit design and an actuarial value of 92%. PERS Choice is the same provider network as PERS Care, but leaner benefit designs with an actuarial value of 87%. PERS Select is the lowest plan value compared to the other two PPO plans with a slightly narrower network and has the same benefits as PERS Choice with the addition of some value-based insurance designs. Similar to the PPO portfolio, if we take no action, the basic PPO portfolio will continue to be impacted by adverse selection. PERS Care will see about 10% annual premium increases from 2022 to 2026 as the healthier members continue exit out of the plan because of their inflated premiums and move to lower value plans. By 2026, PERS Care will lose 60% of its membership. As we've discussed, the PERS Select premium is currently underpriced due to the concentration of healthy risk. Over time, as healthier members continue to move to lower option plans from PERS Care to PERS Choice, from PERS Choice to PERS Select, the premium disparity continues to worsen in the PPO basic program. Next slide, please. These are the 5-year premium projections if we portfolio rate and price the 3 PPO products based on the plan's value starting in 2022. Under portfolio rating, all 3 PPO plans have stable premium increases year over year, as member migrations between PPO plans are no longer impacting the premiums. However, the premiums would be brought much closer together because there's very little difference in the plan value between these products. This does not provide meaningful choice to CalPERS members. With that in mind, as discussed in September, next I will show you the updated projections for replacing the current 3 PPO options with PERS Platinum and a PERS Gold. Next slide, please. In this scenario, portfolio rating is implemented in 2022, and the 3 PPO basic plans are converted to 2 plans, PERS Platinum and PERS Gold. In this new 2-plan design, PERS Platinum would remain the same broader provider network and richer benefits as today's PERS Care with a 92% actuarial value. PERS Gold would be similar to today's PERS Select with the same narrow provider network, but with reduced benefits at 80% actuarial value rather than 87%, meaning it would be less rich benefit design than the PERS Select plans. With these 2 products, we would have a true distinction in benefits and pricing under portfolio rating for the PPO. Next slide, please. These are the premium projections with a 2-year phase-in approach. In this scenario, we split the premium impacts of implementing portfolio rating between year 1 and year 2, meaning that part of the change would occur in 2022 and full implementation would take place in 2023. Following the September board meeting, we began discussing potential benefit design options for PERS Gold with our stakeholder communities. Each organization expressed a desire to gather additional feedback from their various members to better weigh in on the options to reduce the actuarial value of PERS Gold. As a result, we are recommending including the benefit design changes to PERS Gold as part of the 2nd year of the 2-year phase-in. Therefore, for the first year in 2022, we recommend replacing the current 3 PPO plans with PERS Platinum and PERS Gold, with PERS Platinum being the same as the current PERS Care and PERS Gold being the same as the current PERS Select. As the next step of the phase-in approach, we would continue to discuss with stakeholders about the potential benefit design changes for PERS Gold to move towards a benefit design more similar to a standard 80% actuarial value gold level plan. We would bring those proposed changes to the committee in November of 2021 for recommendation to implement in 2023. Next slide, please. With that, I'd like to provide our recommendation. Next slide, please. For the entire basic portfolio, the team recommends adopting portfolio rating with a 2-year phase-in. For the PPO basic portfolio, the team recommends replacing the current PPO basic plans with the proposed PERS Platinum and PERS Gold, with the specific benefit designs for those new plans to be considered and adopted next November, and the final benefit designs in place for the 2023 plan year. This concludes my presentation, and I'm happy to take questions.
Thank you, Ms. Green, for a great presentation. I do have a couple of questions. I have Ms. Green-Ross.
Thank you, Marta. That was very, very interesting, very helpful. I just sort of have big picture questions about the impact of this transparency long term. And so first, I'm curious if we can apply or will apply this model to the other plans, and then if so, you know, how that'll become more public. And I'm just curious about making all this information more public, claims experience, and the impact on our negotiations with these providers, and whether you know how the state's other purchasers are applying this and being transparent about that as well, because I think that information also is the more transparency overall would help all of us public health purchasers.
Great question. Thank you, Ms. Green-Ross. So the pieces that we're proposing to make entirely public are each plan's risk score. So you understand kind of how the proposed premiums would be adjusted. We are also engaged in a whole lot of price transparency initiatives that are not directly related to this, but I think get to specifically your comment. So recently we participated with RAND on a hospital price transparency study where we provided our entire claims experience over a 5-year period in order to calculate the average percentage of Medicare for a wide variety of procedures, both inpatient and outpatient at each hospital in California, to really articulate and understand the performance of each hospital on the metric of pricing in our portfolio. And these sorts of initiatives not only advance the public conversation, which I think is what you're addressing. So how do we all understand how healthcare unit costs are impacting all of us as healthcare purchasers and healthcare users, but also specifically to CalPERS, how is each facility performing in our portfolio, and how do we use that in negotiations moving forward? On the issue of transparency in the portfolio rating process, the state of Washington, which is one that I referenced in the presentation, they also publish health plan risk scores on a routine basis. So it helps build trust and transparency in the whole process.
Yeah, that's great. I think it would help long term on all of that. So
thank you.
Thank you. I have Ms. Wesley.
Thank you. This is really a comment, not a question. And first of all, I wanted to thank Ms. Green and Mr. Molds for their presentation. And you make this stuff very easy to digest. And I very much appreciate it, being new to the CalPERS board and the health committee over the last year. As we move forward, I think it's really important that we as a committee and we as the CalPERS board really focus on how we can help to influence bringing down some of these healthcare costs, because this is the end result of a system that just simply doesn't work for the benefit of patients. There have been anti-competitive practices in Northern California. Those are now headed into San Diego and other Southern California areas. Large healthcare mergers always end up with patients paying more and receiving less care. And our Attorney General Becerra had an initiative, a measure in the legislature last year, SB 977, by now termed out Senator Bill Monning, which dealt with reviews of these health transactions. And I really think that this is something that we as health committee members should start focusing on in ways that we can help support a way to have more say over these exploitative costs to patients. For instance, a C-section in Sacramento is $13,000 more than in LA County. Knee replacement is $15,000 more in Sacramento than it is in LA County. And last time I checked, LA County has a higher cost of living. So it's nothing that we can solve here today on this call, but in order for us to enjoy more appropriate healthcare premiums, that only starts when we start having the hard conversation about how we deliver better price regulation in some way to bad actors in California. And that may indeed include allowing the Attorney General in the future to be able to review health transactions for all healthcare mergers, not just nonprofits, which he already does. That was my comment. Thank you so much.
Thank you. I have Ms. Brown.
Thank you, Mr. Chair. Thank you, Marta, for the information. I want to go to page 22 of the presentation. It's the 2-year phase-in of the new benefits if we approve. It's the PERS Platinum and the PERS Gold. So basically, Marta, what you're saying is the people who are currently in PERS care are overpaying for the services they're receiving, for their benefit design. Is that correct?
That's correct.
And how many of those are there in PERS care? It's roughly.
You know, I don't recall off the top of my head, but I can certainly get the enrollment figures for all of the plans.
Good. So I'm going to request that information, and then so the people who are currently in PERS Select and the other PERS, what's it called?
Choice,
they're underpaying for their benefit design, is what you're saying.
So PERS Choice is a little bit closer to a risk-neutral premium. It's, okay. But PERS Select is significantly under what a risk-neutral premium would be. So
what I want to see is not only what people are in, how many people are in each plan. I'd like to see a dot plot of where they are, because my guess is that majority of the PERS Platinum who are overpaying are in rural areas because they don't have access to HMO. I don't know that, but I'm sure you could just give me a little GIS plot of where these people are. You know, my concern is, I mean, do we have 3 times as many people paying for PERS Choice and PERS Select as we do in PERS Care? I mean, what's the ratio? 3 to 1?
It could be about that, but again, PERS Choice is somewhat similar to a risk-neutral premium. PERS Select is the one that's significantly underpriced.
Yeah, you know, my concern is that if it's 2 to 1 or 3 to 1, that basically, 75% or 50% of the population is going to be paying to help bring down the benefits for our least healthy population. And I don't know that we should be doing that, because when I look at page 22, that $824 in your 2026, I know that's an estimate, but I can't. It would have been like $683 if we left it the same. And so that's a huge increase. We're asking for a lot of people to pay, and I want to know what that number is before I vote on this, because I just want to see how many people are going to have to pay a lot more for their health care. I mean, right now people are struggling, and I have serious concerns about this plan.
I'll be happy to get those figures for you.
Thanks.
Thank you. I have Mr. Miller.
Yes, thank you again for a really clear and understandable presentation. The kind of piggybacking on Director Brown's point, when the pain point for folks who are in the PERS Select over the coming years is really, I think, going to be a hardship for a lot of people. I think it was pretty predictable, and we've had these discussions when these things were being developed, that it looked like we were really trying to more or less kill off the top tier PPOs and push people to move into PERS Select. We were really eager to push people to choose that option because of some of the new features of that option. It was more HMO-like in some respects. People were reluctant, but the cost was such a big driver that it almost, I think, for some stakeholders that I've talked to, they feel it feels like kind of a loss leader bait and switch to get them to abandon the more luxurious, as some people viewed it, PPOs that were higher cost, and go into that because they simply couldn't afford to stay, and the price differential was so attractive. And now it feels to them like, oh, now we've got you, now we'll raise the prices, we'll restructure, and you will no longer even have the option of, the top tier PPO plans, and that we're just pushing the whole thing that direction. And I don't know how we overcome those perceptions or deal with that, but over the past few years, it seemed kind of a predictable outcome that this is where we would end up in terms of the migration patterns from these plans, and it just worries me that the size of the impact on some of our members who are the least, in some cases, able to afford it because of the acuity of their illnesses has forced them to make these kind of choices. So I just raise that as a comment. I think I still don't see a better path forward for us, but it's a painful road to be walking.
Yes, Mr. Miller, I would just add that that's part of the reason why in September we discussed that there are ways to offer lower premium options, but the cost sharing associated with those lower premium options is quite high. And so it is a very difficult conversation, the trade-off between premium and cost sharing, which is why we've struck a middle approach of the PERS Gold.
Thank you. I have Mr. Rubalcaba.
Thank you, Mr. Chair. Thank you again, Martha and Don, for the presentation. In one of the, I'm not sure if it was your memo or Don's memo, but one of the earlier memos that I read, it very succinctly stated what our goal is, which is to provide affordable, sustainable, quality health care. I thought that was very well stated. And I think this approach is trying to get the insurance companies and the medical networks to manage care, meaning if people are chronically ill, the acuity, like Mr. Miller mentioned, that they deal with that they try to stabilize them and improve their health if they can, for example, pre-diabetics. And at the same time, we have to acknowledge that there are geographical access issues, as Ms. Brown mentioned. So I do want to comment and applaud the effort you guys are doing. I came on this board after the decision had been made to get rid of risk adjustment. And so we saw the fluctuation in the rates as everybody was trying to figure out what they would do. But I think this is an effort going back to get them to do what they're supposed to do, promote the best care methods, right? The best practices. and create those networks that would have the best cost efficiency, because they do bring in their patients and try to make sure they meet the primary care physician, what have you. So we're trying to do this, and I applaud you. So my question is, I had a question. You answered it already. Somebody asked on the risk scores, they'll be public. So
Yes.
I guess it fits to my earlier question about the timetable on the rating, on the rate development. The risk scores, they come out of this Milliman.
Yep.
So is it? I know under state law, the actuarial results are the actual results. You can't negotiate them. You can't argue them. Are the risk scores in the same situation where can the carriers try to push back or something like that? Or they're explain how that's going to be once we publish them or release them. Thank you.
Thank you. That's a great question. So the risk scores are the risk scores. So they will, each member in the CalPERS portfolio, if you receive CalPERS coverage, I receive CalPERS coverage. I have a risk score associated with me, and my children have a risk score associated with them. And so what a plan's risk score is the accumulation of all the risk scores of the members enrolled in the plan. So there is no argument over what the risk score of the plan is at the time in which it's run. The only conversation that pertains to the rate development process, which is the same conversation we have today, is what is the next open enrollment period going to do to member migration? So how many healthy or unhealthy members do we predict are going to move in and out of the plan in order to predict the upcoming healthcare costs? That's the central conversation that takes place in rate negotiation. And what's happening right now is because we have adverse selection, we have these volatile member migration patterns, people are moving more quickly. And so the carriers are incentivized to then build in more reserves in their product to potentially absorb those more unhealthy members for those plans that are being selected against. With a portfolio rated environment where we see much more stable member migration patterns and much more stable risk scores, those margins shrink significantly because we can better anticipate how many members are going to move in and out of each plan, because the pricing is no longer driving unhealthy risk in one direction and healthy risk in another direction. So the only part of the negotiation relative to the risk score is what we think the upcoming open enrollment period will do. So how many people are coming in and out of, say, Access Plus, or in and out of Smart Care, or in and out of TRIO, and then what is the predicted risk score once the plan year actually begins. But for the risk score today, I could publish every plan's risk score today. I could do it again next week. I could do it in January, and that will be a snapshot in time based on the enrollment of that plan today.
Thank you. That's good to know. Appreciate it. Mr. Fechner, unless there's other comments, I would move that we adopt staff recommendations to start the implementation process.
Thank you for the motion. Is there a second?
This is Wesley. I'll second it.
Was that Ms. Wesley seconding?
Yes.
Thank you. All right, motion be before you. We do have some requests to speak from the audience. I believe we have up to 5 folks that wish to speak. Mr. Fox.
Yes, Mr. Chair. First off, we have from RPEA, Joanne Hollander.
On RPEA, can you hear me?
We can.
Thank you for listening to me and giving me an audience. Thank you, board. You're doing a great job in making a very tough decision, and the staff, you're working very hard. I represent a lot of people in RPA. About 60% of our members are in public agencies and schools. The rest are state employees. So there are some concerns about the cost to the employees and to the agencies having to bore the cost of these increases and changes in the PPO plans in particular. And I did a little analysis based on some discussion we had back in October 9th. It was a risk mitigation meeting with the staff, and we talked about, options, design options, and they said, okay, here's the one that we ended up hearing about on November 12th, but there was going to be some other options, such as a 25 75 for the select plan, which would be gold, and the PERS care plan, which would be platinum, would have been possibly looked at as an 85-15. But when the November 12th meeting came up, there was no option discussed with us. We were told it's just going to be the PERS care current rate under platinum and the PERS select under gold, and that was it. There was no discussion. We weren't given an option to discuss it or ask about it. And that's one of the problems with this death spiral with the PERS care plan, because you're really not addressing the fact that the 90-10 plan is just too rich. It's expensive. And I did a comparison between page 19 and 22, the current rates, and I'm not saying we want to keep those, I'm not suggesting that, but with what is finally being proposed. The PERS Select folks, as Ms. Brown said, they're taking a huge hit. They're going to be taking a 16.98% increase for the next year, 2021, and then following year they're going to be taking a 10.7% increase. And now the choice folks are going to be taking, if they go into the platinum plan, we'll be taking about a 5.8% increase next year. However, if you look at the care platinum, they're going to be taking a 24.4% decrease. So you have the other PPO plans or the select plan basically subsidizing them. And this is crazy. You're not really addressing the PERS care issue, which is now platinum. You did suggest these other options. We never got a response. We were just said, this is what it's going to be, period. Marta told us that. And I think that's very unfair to the stakeholders who really put a lot of time into this. And it isn't fair to the employers or the employees that do have to fork up that money out of their pension to pay for these health benefits. And I know I've been talking about this for a couple of years with you folks, but no one's really listening. And
all under your time has expired.
Thank you.
Thank you. Mr. Fox.
Yes, Mr. Chair. Next up, we have Mr. Tim Behrens, California State Retirees.
Thank you, Kelly. Committee members, board members, CSR supports the gold platinum plan. For our members, there's no significant increase in cost and no significant loss in our health plans. So we support the plan to move in 2022 to the gold platinum health benefits. Thank you.
Thank you. Mr. Fox.
Yes, Mr. Chair. Next up, we have from the town of Truckee, Nicole Casey.
Comment. Hi there. Thank you for letting us comment on this item. We just wanted to point out that in the town of Truckee, we aren't being given access to any additional plans. So we're basically being asked to take on the risk of other areas and higher cost plans that we don't even have access to. It feels pretty unfair when we're asking our members who don't have access to great care. Already, I have employees who are driving an hour down to Nevada to try and get access to a doctor, and we're asking them to take on additional costs for this program without even giving them access to additional plans and programs, especially since just a couple years ago, we were asked to take on the risk for the Bay Area, which increased our rates as well. So as you're designing these plans, please keep in mind that you have specific areas which are not being given access to the supposed, I think your words were price and quality options that you're giving access to everyone else in the state. So thank you for the opportunity to comment, and we hope that you consider us, and we'd be happy to participate in any stakeholder groups that you have still running on this.
Very good. Thank you for your comments. Mr. Fox.
Yes, Mr. Chair. Next up, we have from CSR, Larry Woodson.
Hello, can you hear me?
Can hear you.
Okay. Thank you for the opportunity to comment. Just amplifying a little bit on Mr. Barron's CSR support for this. We do thank the staff for all their hard work, also for all the transparency. I think there's been a lot of discussion, and unlike one of the previous commenters, I think we, even though there was comments given about the increase in the lower price, the current proposal considers that by doing a 2-year phase-in, which makes the first year increase less. So I think that does address some of the concern. Clearly, the value-based approach does result in an increase in premium on the lower plans, and we recognize that. But it significantly lowers and stabilizes the higher cost death spiral plans, which is populated by a lot of our older, sicker members, and those, the values of those plans is not commensurate with the cost. And so the other thing is that, I asked and received a new estimate on the monthly contributions, because that's part of the equation that, members need to be considering when they're considering this approach. And the good news is that the monthly contribution actually goes up over the current contribution with this new strategy. It goes up to $840 a month for a single ratepayer, and that means for retirees that are fully vested, that more than covers any increase in the lower cost plans if they're in select. So I think, some actives would be paying more, but if you're an SAIU, what they contribute, they've negotiated along with the lawyers better contribution rates, which would more than cover the increases. So I think it's better not to kick this thing down the road again if it didn't pass. And we agree with the Platinum Gold. Most the choice members would migrate to Platinum because the cost would come down considerably and be affordable to them. And we are concerned about benefit design changes in the second year, but we have an opportunity to input then. So thank you for the opportunity to comment. That's all.
Thank you. Mr. Fox.
Yes, Mr. Chair. Next up, we have from RPEA, Mr. J.J. Jelensik.
J.J. Jelensik, Director of Health Benefits for RPEA. RPEA is not taking an organizational position on this issue. We did not have enough information to make a reasonable evaluation. We do not know what information staff has told the board in closed session that has not been shared with constituents. This project is designed not to protect the health risks of members, but the financial risks of the health plans. We're not convinced that protecting PERS care is in the best interest of the majority of the members. If members do not value care enough to pay for it, it is not clear that the members who accept lower insurance protection offered by PERS Choice and their narrower network of PERS Select should be asked to subsidize the richer plan. It is also unclear that protecting those HMOs with the highest costs by asking other members to subsidize the costs serves the members as a whole. If plans cannot compete, there is little reason to keep the zombies alive. It's hard to believe that a plan that increases the cost of 80% of the members to lower the cost of 20% of the members is justified. The staff has said that the issue is healthcare risk, but when you look at the HMO data, it appears to be a backdoor rural subsidy. Staff has said that geography and costs are not considered in the migration. However, the Milliman Advanced Risk Adjusters, which you are going to use, provides and uses both provider costs and geography. It's just a coincidence that the higher the rural exposure, the higher the subsidy. The plan is not to adjust the premiums between regions 1 and 3 because that is just costs, not health differences. You can't have it both ways. Either costs and geography matter or they don't. If you want a conversation about rural subsidy and subsidizing the sickest, we are willing to have that discussion, but it should be direct and not backdoor. Also, I hope that the subsidies and surcharges will be made explicit when the rates are set. On the other hand, that would involve transparency, so I'm not really expecting to see it despite what staff has said. Thank you.
Mr. Fox, please.
Yes, Mr. Chair, the last caller on item 6B, Terry Brennan.
Mr. Brennan, are you there?
Oh, shoot. Yeah, I'm here now. Sorry. When I put it to my ear, I put it on mute. First, let me start by thanking Don and the whole healthcare team for reaching out and explaining to stakeholders what can be a very complex issue. And I appreciate all the work they put into it. I think it's clear that this is an effort to avoid disastrous consequences of the status quo. If we do nothing, the consequences are fairly dire. And this is an effort to avoid that. In terms of disruption, we need to look back at history. We've done this before. There was disruption when we made the transition, and there was significantly more disruption when we eliminated it. So I think our concern is making sure we're more strategic and surgical with this risk mitigation than the blunt instrument used last time that caused significantly more disruption and premium changes going forward. Thirdly, members have expressed an interest in innovation and attacking cost drivers. There's no better way than to price these plans actuarially to encourage folks to attack the cost of healthcare and be rewarded commensurately with their innovation. And then in terms of the plan option, I mean, this is kind of like we're playing with a Jenga game here, and you don't want to pull out two boards at once. The idea of rolling the premium impact over 2 years is very smart, but the idea of adding on top of that an additional plan option really complicates the impact of one over the other, and you can make that assessment somewhere later down the road. For that reason, SEIU is in support of the motion before you, and we urge you to support it as well. Thank you.
Thank you. Anyone else, Mr. Fox?
Mr. Chair, that concludes public comment on item 6B.
Thank you very much. Before I go back to comments, Mrs. Green or Mr. Moles, do either one of you have any rebuttal to the comments from the callers?
The one that sticks out to me is Ms. Hollander. So the conversation that we're going to have relative to the final benefits design for PERS Platinum, PERS Gold will continue. We did introduce some concepts. She did reference our October meeting, which we did introduce some concepts at that meeting. That conversation isn't done. That conversation is just going to extend over the next year, and we'll bring to the board final recommendations for the designs for PERS Platinum and PERS Gold. It's just as Mr. Brennan just indicated, doing both of those things at the same time was not enough time. for stakeholder to give full-throated and meaningful impact. So we do intend to extend that conversation, and I apologize if that was not clear.
Very good. I appreciate the explanation. I have Ms. Brown.
Thank you. Marta or Dawn, how do these changes impact what the state pays for healthcare? Does it impact them at all, and do they have a comment on this?
So the risk mitigation, the portfolio rating has a very, very minor impact on the contribution, but the change from 2 PPOs to a single PPO will impact the state contribution, because right now what happened is the state contribution went down significantly in the most recent plan year because PERS Select in the calculation overtook PERS Choice, because they use a very specific calculation of just subscribers in state employment. And so that subgroup of folks became larger than the PERS Choice group of folks. So the state contribution actually dropped about $50 a month. And so when we go to 2 plan options, that will change the calculation. And so that would increase the state contribution.
All right, thank you. And then, you know, I too have, like I expressed earlier, I have concerns about the PERS, the PERS Gold, so not only increasing dramatically, but what those benefit design changes are. And I recall when we last talked about this in a public meeting, or maybe the time before, you talked about how we would make changes so they would feel the same, but not that they would be the same. And so my concern is that we don't know what those benefit design changes are. But I mean, if we're talking about increasing copays or increasing deductibles, so we've increased their premium and we're going to increase their monthly out of pocket. And I, you know, I would not be able to support that. I think for me, it's premature to vote on this plan. I'll be voting no if we end up going forward at this point, because I need more information. Thank you.
Thank you. We now see no other requests to speak. We have a motion before us. Ms. Hopper, please call the roll.
Margaret Brown.
No.
Henry Jones.
Aye.
David Miller.
Aye.
Elena Ortega.
Aye.
Ramon Rubalcaba.
Aye.
Teresa Taylor. Shonda Wesley.
Aye.
Karen Green Ross for Betty Yee.
Aye.
Mr. Chair, I have 6 ayes, 1 no, made by Margaret Brown. Motion was made by Ramon Rubalcaba, seconded by Shonda Wesley for agenda item 6B, risk mitigation strategies.
Thank you very much. So before we go to item 6C, we are going to take a 10-minute comfort break. So everyone can turn off their cameras if they'd like for a moment. When we come back, our IT staff is confident that WebEx may have fixed their problems for the day. So if you want to turn your cameras back on, we'll see how that works. So again, we're going to take a 10-minute break. We'll reconvene at 11:40.